Hello, this is Dr. Andrew Dauber from the Cincinnati Children's Hospital Medical Center. Welcome to this educational activity on best practices in managing growth hormone deficiency.
The following audio is part of a certified educational activity titled Navigating Diagnostics and the Management of Growth Hormone Deficiency in Children and Adults. Access the entire activity and complete the post-test at www.peerview.com/PUB. Downloadable infographics and additional content are also available.
Short stature is one of the most common reasons for children to present to the pediatric endocrinologist. The strict definition of short stature is a height below -2 standard deviation for a given population, which represents approximately 2% of the population. Growth hormone deficiency, on the other hand, should only be considered when short stature is severe or there is a significant fall-off in height percentiles. True growth hormone deficiency is a rare disorder with an estimated prevalence of 1 in 4,000 individuals. And in the United States, more than 50,000 adults are estimated to be growth hormone deficient. There are approximately 6,000 new cases reported each year, including children with growth hormone deficiency who transition to adulthood. Growth hormone deficiency has a profound impact on children. The most significant morbidity of growth hormone deficiency relates to the severe short stature that results from a lack of growth hormone. In prior studies, which looked at severe cases of untreated children who reached a final adult height without growth hormone replacement, they reached an average height of 143 centimeters in men and 130 centimeters in women. In addition to the short stature, there are a number of other physical features that are seen in true growth hormone deficiency. Children may have a cherub-like facial appearance with a flat nasal bridge and mid-face hypoplasia. Other clues to growth hormone deficiency could be other midline defects, such as a single central incisor or a cleft palate, which might point to midline defects in the pituitary or hypothalamus as well. Children born with congenital growth hormone deficiency, especially in the setting of multiple pituitary hormone deficiency, may present with a number of associated symptoms, including neonatal hypoglycemia, prolonged jaundice, micropenis in males, and early growth failure. Bone age is usually delayed, and puberty can be delayed as well. Mortality in children with growth hormone deficiency is almost entirely due to other pituitary hormone deficiencies and not to the growth hormone deficiency itself. In adulthood, growth hormone deficiency has multiple effects on one's health. First, there's a reduced lean body mass and increased visceral adiposity. Growth hormone has lipolytic actions, so without growth hormone, there's an increase of this visceral fat. Individuals with growth hormone deficiency also have reduced bone mineral density and can be at an increased risk of fractures. They have decreased muscle strength and exercise capacity. Overall, they can have a diminished quality of life. There are abnormal lipid profiles, and there can also be effects on cardiac function with impaired cardiac performance and an increased prevalence of cardiovascular disease. And there have been multiple studies that have documented an increased relative risk of death in adulthood from cardiovascular causes resulting from altered body composition and dyslipidemia. In adults, they also could have an increased risk of mortality due to other pituitary hormone deficiencies as well. In terms of its physiology, growth hormone is produced in the anterior pituitary gland and secreted by the pituitary and released into circulation. The release of growth hormone is under the control of two different hormones released by the hypothalamus. Growth hormone releasing hormone has a positive effect on growth hormone release, while somatostatin has an inhibitory effect on growth hormone release. Growth hormone is released in a pulsatile fashion and leads to increased levels of IGF-1. IGF-1 stands for the insulin-like growth factor 1 and is the major mediator of growth hormone action. IGF-1 is made in the liver, but is also made at other target tissues, including the growth plate itself. While a majority of growth hormone's growth effect is mediated via IGF-1, growth hormone also has direct effects on the growth plate that are independent of IGF-1. Causes of growth hormone dysfunction can either be congenital or acquired, and there are secondary causes for growth hormone deficiency, including psychosocial deprivation, hypothyroidism, other chronic diseases such as poorly controlled diabetes, and certain drugs, nutritional deficiencies, and others. So in the congenital causes, it's useful to separate those due to genetic mutations or due to structural brain malformation. So for example, patients with midline defects such as holoprosencephaly, septo-optic dysplasia, which is also referred to as optic nerve hypoplasia, or an anatomic defect in the development of the pituitary gland, often referred to as pituitary stalk interruption syndrome. In terms of the genetic etiologies, the specific causes of isolated growth hormone deficiency are primarily limited to defects in the growth hormone gene itself or in the receptor for growth hormone releasing hormone. In terms of acquired causes, the most common and worrisome acquired cause that one must be aware of is a central nervous system tumor, and the most common one being a craniopharyngioma. A craniopharyngioma is a non-malignant tumor. It's an embryonic remnant from cells from the Rathke's pouch, which is the developmental area that leads to pituitary gland development. Other tumors to think about primarily are optic nerve gliomas, germinomas, and other pituitary adenomas. Other acquired causes of growth hormone deficiency include brain trauma, rarely infections such as encephalitis or meningitis, and commonly seen cranial radiation, which is used to treat other malignancies. And there are other systemic infiltrative diseases like histiocytosis, which can lead to acquired growth hormone deficiency as well. There are multiple strategies of how to approach the diagnosis of growth hormone deficiency. First and foremost, one must take into account the auxillologic measurement. So this is the measurement of height and weight. Typically, individuals with growth hormone deficiency will have a progressive fall off in their height with a preservation of their weight, and in fact, they might have an increase in their BMI. Biochemical testing includes both screening tests as well as provocative growth hormone stimulation tests. The most commonly used screening tests are the IGF-1 level as well as the IGF binding protein 3 levels. Imaging studies can also be quite helpful, in particular pituitary MRIs. Pituitary MRIs can be used to look both for congenital malformations of the pituitary gland as well as to look for central nervous system tumors. Genetic testing is not routinely used for all patients with growth hormone deficiency. However, in patients with multiple pituitary hormone deficiency, it can be quite useful as different pituitary transcription factor mutations can involve different pituitary hormone deficiencies. Additionally, if there is a familial pattern to the growth hormone deficiency, it can be useful to test the growth hormone gene or the growth hormone releasing hormone receptor as well. It is important to note that children with isolated growth hormone deficiency who are retested biochemically as adults will often have normal testing as adults. In terms of when to consider testing for growth hormone deficiency, there are a number of growth parameters that can be useful. So the Growth Hormone Research Society published consensus guidelines which suggested that if a patient has severe short stature with a height below -3 standard deviation, the diagnosis of growth hormone deficiency should always be considered. If their height is very discordant from the midparental target height, which is a proxy of their genetic potential, then one should consider. Or if the height is below -2 standard deviation and they have a slow growth velocity, or even if the height is not short, but they have a very slow growth velocity, you must consider acquired causes of growth hormone deficiency. And of course, if somebody has a known intracranial lesion affecting the pituitary gland, or they have other signs of multiple pituitary hormone deficiency, then one must consider the diagnosis of growth hormone deficiency. In terms of measuring various hormone levels, it is, again, key to realize that random growth hormone levels themselves are not useful. However, IGF-1 and IGF binding protein 3, which are proxy biomarkers of growth hormone action, both have longer half-lives and are much more stable. They can be measured as a marker of growth hormone deficiency. And low values of IGF-1 and IGF-BP3 are suggestive of growth hormone deficiency. However, there are multiple reasons one may have a low IGF-1 and or IGF-BP3 level, as these are both more sensitive to nutritional state or other chronic systemic disease. It is important to compare IGF-1 and IGF-BP3 levels to specific pediatric normal ranges, which depend on the patient's age, sex, and pubertal status. For growth hormone stimulation tests, there are a number of different techniques and agents that are used. The idea here is to give a provocative agent that stimulates growth hormone release and then measure the pituitary gland's capacity to increase growth hormone secretion. So the most commonly used pharmacologic stimuli are arginine, insulin, glucagon, clonidine. Typically, in order to make a definitive diagnosis of growth hormone deficiency, you need to perform 2 growth hormone stimulation tests. Serum growth hormone levels are then measured at multiple time points after the agent is administered, and current guidelines in the United States recommend using a peak serum cutoff of 10 for the diagnosis of growth hormone deficiency. That being said, there is no specific cutoff that reliably distinguishes patients who are normal, healthy, non-growth hormone deficient but have short stature with those with isolated growth hormone deficiency. The Pediatric Endocrine Society of the United States recently came out with consensus recommendations on the diagnosis and management of growth hormone deficiency. They strongly recommend that growth hormone provocative test results should not be relied upon as the sole diagnostic criterion for growth hormone deficiency. That means that if a patient has a normal growth rate and mild short stature and a normal IGF-1 level, growth hormone stimulation tests that have a peak level below 10 should not make a diagnosis of growth hormone deficiency alone. Also, they point out the need to use a harmonized growth hormone assay when doing growth hormone stimulation testing. The Pediatric Endocrine Society also discussed when growth hormone stimulation testing is needed or can be skipped, and they recommend that in patients who meet all of the following conditions, meaning they have auxological criteria with height or growth velocity criteria suggestive of growth hormone deficiency, and they have a known hypothalamic pituitary defect on imaging, such as an ectopic posterior pituitary or severe pituitary hypoplasia, or have previously had a brain tumor or radiation, and they have an additional pituitary hormone deficiency, those patients should not need to undergo growth hormone stimulation testing. They also point out that growth hormone deficiency as part of congenital hypopituitarism can be diagnosed in a newborn with hypoglycemia who does not have a peak growth hormone level above 5 and has at least one additional pituitary hormone deficiency. Finally, the Pediatric Endocrine Society makes a recommendation that children who are in the peripubertal range, so boys over age 11, girls over age 10, who are undergoing growth hormone stimulation testing should have sex steroid priming done. There's much debate as to the appropriateness of this recommendation, with some people recommending that sex steroid priming should be done in all children regardless of age, and others feeling that this is a not physiologic state and that sex steroid priming should not be done at all. My personal practice is to perform sex steroid priming in all children, as I believe it leads to a more reliable diagnosis that the patient has a true organic growth hormone deficiency. In terms of imaging, all children diagnosed with hormone deficiency should undergo a contrast-enhanced MRI with a specific attention paid to the hypothalamic pituitary region. And the point of this is both to rule out structural abnormalities as well as to assess for any CNS tumors and in particular a craniopharyngioma. In terms of genetic evaluation, in patients being evaluated for short stature, every girl with unexplained short stature, especially if it is discordant from their parents' height, must get a karyotype to assess for Turner syndrome. It is very important to note that girls with mosaic forms of Turner syndrome can have none of the obvious physical findings of Turner syndrome outside of isolated short stature. In boys with genital abnormalities, a karyotype would also be warranted. And then there are other specific genetic testing or referral to genetics that can be done if the patient has syndromic features that suggest another syndrome associated with short stature, such as Prader-Willi syndrome, Noonan syndrome, Russell-Silver syndrome, or others. Children who have notable skeletal abnormalities or disproportionate short stature on examination should be evaluated for metabolic bone disease or skeletal dysplasias. And this is typically done through a skeletal survey, which is a complete X-ray panel of the body. It is very important to make a timely diagnosis of growth hormone deficiency. Failure to recognize pathologic growth can lead to missed or delayed diagnosis of systemic, endocrine, nutritional, and genetic diseases. Treatment with recombinant human growth hormone is very effective in improving final height, and all of the studies show that the earlier age at treatment and the longer duration of treatment prior to the onset of puberty leads to better height outcomes. Growth hormone deficiency is also associated with low bone mineral density and adverse effects on body composition and lipid metabolism, and delayed diagnosis can lead to poor outcomes in these regards. However, it is important to make an accurate diagnosis because false positive diagnoses can lead to children getting unnecessary daily injections. It can stigmatize the children and tell them that they have a disease which they do not, can expose them to potential adverse effects of growth hormone, and it can lead to a significant economic burden both for the family and the healthcare system. We will now be discussing how to optimize management of growth hormone deficiency. The primary goal in growth hormone deficient patients is to normalize height during childhood and adolescence and attain an adult height within the normal range and within the appropriate range for the individual's family, i.e., reach their genetic potential. Recombinant human growth hormone was first approved by the FDA for pediatric growth hormone deficiency in 1985. It has the same amino acid sequence as naturally occurring human growth hormone. Since that initial approval in 1985, growth hormone has now been approved for a number of other indications. In 2005, the U.S. FDA approved treatment with IGF-1, that's recombinant insulin-like growth factor 1, for the long-term treatment of growth failure in pediatric patients with severe primary IGF-1 deficiency, which is defined as both a height and IGF-1 levels below -3 standard deviations. Recombinant IGF-1 is not approved in patients with secondary IGF-1 deficiency that is due to either growth hormone deficiency or malnutrition or hypothyroidism or other chronic illness. The Pediatric Endocrine Society recently published guidelines for the treatment of children and adolescents with growth hormone. They strongly recommend the use of recombinant human growth hormone to normalize adult height and avoid extreme shortness in children and adolescents with growth hormone deficiency. Current treatment of growth hormone deficiency consists of daily single subcutaneous injections. It has been shown that daily treatment is more effective than treating just a few days per week. Dosing should either be based on body weight or body surface area, and they recommend starting with an initial growth hormone dose of a range of 0.16 to 0.24 milligrams per kilogram per week, with subsequent individualization of dosing based on growth hormone response, potentially IGF-1 levels. It is important to note that there are multiple different formulations of recombinant human growth hormone marketed by a number of different companies. Each of these formulations has a slightly different growth hormone dose range that has been approved by the FDA. Higher doses and continuous therapy for a longer duration can lead to greater efficacy, although in patients with profound growth hormone deficiency, a low dose of growth hormone is typically adequate. IGF-1 levels can be used as a biomarker to determine the optimal growth hormone dosage for each patient. It is also a very useful marker to check compliance with growth hormone treatment. If the serum IGF-1 level rises above the upper limit of the laboratory-defined normal range, one should strongly consider decreasing the dosage of growth hormone in order to prevent long-term safety concerns. When a child approaches their near final adult height, growth hormone should be discontinued. This is typically done when the growth velocity has fallen between 2 to 2.5 centimeters per year. In adult patients, the dose required of growth hormone is much lower, can be more than tenfold lower than that needed in pediatric patients. So once a child is transitioning from the pediatric dosing to adult dosing, they will be retested to ensure that they continue to have growth hormones as adults, and then started on a much lower dose. Growth hormone doses in adulthood are titrated according to the clinical response, side effects, and IGF-1 level. One must take into account whether oral estrogens are being taken in adult females, as higher doses of growth hormone are needed when oral estrogens are used. Additionally, older patients have increased susceptibility to growth hormone-related side effects and thus require lower doses of growth hormone. Growth hormone has multiple beneficial effects. As noted, the primary effect in childhood is to promote height velocity. It will decrease body fat and increase the lean body mass, including muscle and bone. Growth hormone replacement can reverse unfavorable lipid profiles and improve cardiac function. And growth hormone treatment has the potential to influence later health risks, including the risk for future cardiovascular disease and osteoporosis, and has even been demonstrated to improve quality of life in some groups of patients with growth hormone deficiency. In terms of monitoring response, children with growth hormone deficiency should be seen in the office every 3 to 6 months for careful measurement of their height and following their growth velocity. Typically, bone age x-rays are repeated on an every 1 to 2 year basis to monitor whether the bone age is advancing in concordance with the chronological age. In childhood, consensus guidelines do not recommend any formal cardiac testing or bone density testing or measurement of lipid profiles. In adults, you obviously have different treatment goals, so IGF-1 levels should be monitored closely during dose titration and then every 6 months once the desired level has been achieved. And then clinical assessments, adult patients should be checked for side effects every 6 months. Lipid panels and fasting glucose should be checked every 12 months. Thyroid and adrenal function need to be monitored, and bone density scans should be monitored every 1.5 to 2 years. And then if there has been no objective benefit after 1 year in an adult patient, growth hormone should be discontinued. It is very important in childhood to monitor for the development of adverse effects of growth hormone therapy. The 3 adverse effects that are most concerning in childhood are, first, the development of idiopathic intracranial hypertension, often also referred to as pseudotumor cerebri. This presents with severe headaches that can be worse first thing in the morning or upon lying down. It can also be accompanied by vomiting. A good fundoscopic exam should be done in order to look for signs of papilledema. And if that is not able to be obtained in the provider's office, they should be referred to an ophthalmologist for a dilated eye exam. If papilledema is present, the patients will often need a lumbar puncture to confirm that they have increased intracranial pressure, and growth hormone needs to be discontinued. Typically, the intracranial hypertension will resolve on its own with the discontinuation of growth hormone therapy, but occasionally additional medications are needed. Once all of the symptoms have resolved and the papilledema is no longer present, growth hormone can be reintroduced at a lower dose with a slower titration in the dose increases, and typically it does not recur. The second adverse effect to be concerned about is something called a slipped capital femoral epiphysis. This is a slippage of the top of the hip joint, which can be severe and require surgical correction. Any child on growth hormone therapy who complains of either hip or knee pain or presents with a new limp must have hip x-rays performed to assess for the possibility of a slipped capital femoral epiphysis. If present, referral to orthopedics is warranted. Finally, in patients with pre-existing scoliosis, they can have worsening of the degree of scoliosis. The Pediatric Endocrine Society recommends that monitoring for these 3 adverse events of intracranial hypertension, a slipped capital femoral epiphysis, and scoliosis progression should happen at every follow-up visit. Growth hormone also is known to be a counter-regulatory hormone, which increases the body's resistance to insulin. Therefore, there is a theoretical risk for problems in glucose metabolism in patients who have increased risk of diabetes at baseline who are then treated with growth hormone. There are also theoretical risks of neoplasia in later life due to growth hormone treatment. Many studies have shown that patients who at baseline do not have an increased risk of neoplasia do not develop increased risk of tumors while on growth hormone therapy. In patients who have growth hormone deficiency associated with multiple pituitary hormone deficiencies or with an anatomic defect of the pituitary gland, one must definitely reassess both the adrenal and thyroid axes after initiation of growth hormone therapy. Additionally, the Pediatric Endocrine Society recommends sharing of information on the risks of therapy and having an informed discussion with the family about the known and potential risks of growth hormone therapy. When it is time to transition a child to growth hormone treatment as an adult, first and foremost, it is imperative to reconfirm the diagnosis of growth hormone deficiency, then to adjust the dosage to be an appropriate dosage for adult growth hormone replacement, and then retitrate the treatment to assure an IGF-1 level within the upper half of the normal range. There have been a number of different groups that have made recommendations about how to transition care from childhood to adulthood. The Pediatric Endocrine Society, again, stresses the need to reassess whether growth hormone deficiency is persistent. Patients with multiple pituitary hormone deficiency or patients with a known structural defect in the pituitary hypothalamic region or patients with prior malignancy and CNS irradiation all have a much higher risk of having persistent growth hormone deficiency into adulthood. In patients with isolated idiopathic growth hormone deficiency and with normal MRI findings, those patients should definitely undergo a repeat IGF-1 level. There are multiple challenges to being on long-term recombinant human growth hormone therapy. As we discussed, currently this is a daily subcutaneous injection therapy. While this is done subcutaneously with a small needle and is really not extremely painful, this still can be quite a challenge in children. Non-compliance has been reported in up to 82% of patients. Depending on the formulation used, it is not always very simple to prepare the medication and inject it. And many studies have shown that even in patients who do continue to take growth hormone therapy, that their adherence rates are quite low, meaning that they miss multiple of the indicated doses. This will then lead to decreased efficacy of the treatment. Numerous barriers to adherence have been identified, such as forgetting to take the injection, forgetting to refill prescriptions, being away from home as children transition to adolescence, just being simply exhausted from having to do daily injections for many years, difficulty obtaining medication from pharmacies, and there are multiple strategies to try and improve adherence, including support from the care team, frequent education, and reminders. There have been a number of innovations in growth hormone delivery systems over the year, including single-use syringes, which are preloaded with growth hormone. I would say one of the most commonly used innovations nowadays is the reusable and disposable pen injection devices. There are multiple different devices, each of which has pros and cons, but these can greatly simplify the administration of growth hormone to children. Additionally, the pens have very small needles, which are often less painful. Needle-free devices are being developed as well. Currently on the horizon, there are many companies attempting to develop long-acting growth hormone formulations. In the past, a few formulations had been developed. In the United States, there are no currently approved long-acting growth hormone formulations on the market. There are a number of phase 2 and phase 3 clinical studies that are currently ongoing for long-acting growth hormone preparations. Some preliminary results of these studies have been published in abstract form, and we are all awaiting the definitive results. One phase 3 trial, the Velocity trial, which assessed some of Varitan versus daily genotropin, recently reported their results in a press release, and they did not meet the primary endpoints of non-inferiority. There are a number of useful resources for both clinicians and patients, including the Pediatric Endocrinology Nursing Society website, as well as the Pediatric Endocrine Society clinical practice guidelines that were recently published. Both the Magic Foundation and the Human Growth Foundation have support information available for families, which can be quite useful. Finally, the important take-home messages. There are a myriad of etiologies for growth disorders, which can be challenging for the primary care clinician to evaluate and manage and require timely referral to endocrinology for further detailed evaluation. Early diagnosis and treatment with recombinant human growth hormone can improve the clinical outcome of disease. The diagnosis of growth hormone deficiency should take into account growth patterns, biochemical testing, as well as imaging findings. Growth hormone stimulation tests alone should not be the sole diagnostic test used to define growth hormone deficiency. And new long-acting growth hormone formulations are currently being developed, which will hopefully help with long-term patient compliance.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at www.peerview.com/PUB. This activity is supported by an educational grant from Novo Nordisk Incorporated.